stroke is a nebulous term that means brain death. The brain is in G0. Once the brain dies, it doesn't come back. So it's a big deal. But stroke usually refers to ischemic stroke from a thrombus, though stroke is thrown around to mean any kind of stroke. So what I want to do is go through the different types of stroke, the presentations you may see in life, but more likely what you're going to see on the test, the workup for stroke, and then how you manage it, both in the very acute phase and in the chronic phase. Start off with the pathogenesis of stroke. Now, I want you to see the word stroke to mean brain attack, in the same sense that a STEMI is a heart attack, a stroke is a brain attack. Some sort of compromise of a blood vessel that leads to death of brain distal to it. There are 3 types of brain attacks, of strokes. Thrombotic, embolic, and together these 2 are called the ischemic strokes, the subject of this lesson. And also we have the 3rd kind, hemorrhagic. And we discuss hemorrhagic more in the neurosurgery videos in surgical subspecialties. This is the brain, arteries of the brain. In a hemorrhagic stroke, blood leaks out, gets into the parenchyma. This, what I've just drawn, is an intracerebral hemorrhage. You could also have bleeding around the brain, and that would be a subarachnoid hemorrhage. But it's the intracerebral hemorrhage which is the true hemorrhagic stroke. We're going to talk a little bit about this, but not so much. On the other hand, the thrombotic stroke, same blood vessels, has an occlusion of that blood vessel. And everything distal to it, everything perfused by the vessel, is going to die, especially the watershed areas that are at highest risk. This is the true equivalent of a heart attack. This is the STEMI. And it is caused by the same pathogenesis, an atherosclerotic plaque. Cholesterol deposits, lipidated macrophages, the plaque rises and eventually ruptures acutely, forming a platelet thrombus. This thrombotic stroke has the same risk factors as coronary artery disease. Hypertension, diabetes, dyslipidemia, smoking, obesity, age, and family history. And it happens the same way. So you'll see there's parallels to treatment. Embolic stroke also causes something to gum up the blood vessels. In the area distal to the area that's gummed up, dies, especially the watershed areas. But in this case, it does not come from a plaque. It comes from somewhere else. And where it could come from informs us of what workup we should do. This could be carotid artery stenosis. It could be dissection of the carotid artery, or it could come from the heart itself in the way of AFib or having a bad valve where a thrombus forms. Embolic means there is a thrombus somewhere and then it flicks off and goes to the brain. Now you could have other things embolize. Septic emboli, for example, could be a vegetation from infective endocarditis. In this lesson, we're going to refer to only clots that are caused by platelets, that cause platelet clots. But however it gets there, they break off and go. These are ischemic, this is hemorrhagic. We're going to talk about ischemic only, and we're going to effectively treat thrombotic and embolic the same. The patient presentation, the hallmark of a stroke, is a focal neurologic deficit that could be localized to the brain. You do not have to do that intense level of neuroanatomy detail like you did for step 1. Really what you should be looking for is, do you know the major branches of the brain arteries? And that's the circle of Willis. A whole thing comes from the carotid arteries. This is the anterior circulation, cerebral arteries. They feed the feet and the legs. The middle cerebral artery feeds the hands, arms, face, and don't forget about speech. The posterior cerebral arteries are mainly visual cortex, presenting with visual disturbances and cortical blindness, and the posterior cerebral arteries form the basilar artery, which arises from two vertebral arteries. While basilar artery could cause locked-in syndrome, the vertebrobasilar vasculature causes syncope as its presentation. And don't forget about the cerebellum. The cerebellum maintains coordination, dysdiadokinesia, inability to do rapidly alternating movements, finger to nose, and most importantly, ambulation. Ataxia is a sign of a stroke of the cerebellum, and you may not be able to detect another lesion because the cortex would be intact until you walk them. Always walk your patients, unless they have complete paralysis of one leg, and then you know you can't actually walk them. This is as deep you have to go, unless you're going to become a neurologist, to organization and localization of a lesion. But remember that localization to the brain means that you know there are upper motor neuron lesions, lower motor neuron lesions, decussations, blah, 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 blah. Blah, 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 because only thing you have to understand is a right-sided stroke, right brain damaged, left body affected. Huge stroke of the AC and MC on the right side, you lose your left arm and left leg. Right side of brain, left side of body. Not ever bilateral. If it's bilateral body, it's not a stroke. It could be multiple strokes, but it's not a singular stroke. Focal neurologic deficit localized to the brain, and then one of these four scenarios on your exam. The vasculopath. The person who is the hypertensive, diabetic, dyslipidemia, smoking, has peripheral vascular disease, has coronary artery disease. If they've got blockages in their heart and leg arteries, there's probably blockages in their brain artery too. The second is the one who's set up for embolic stroke. That is someone who's got a fib or a flutter, or who has a prosthetic valve, especially if they're not on anticoagulation. It's actually why we put people on anticoagulation, is to avoid an embolic stroke. Number 3 is not a common presentation, but it's something that the test can use to get you, and that's going to be a young woman with pain in her neck, especially following trauma. Now you may think, she's faking it, it's nothing wrong with that neck, or you might be thinking, no, she just had a concussion or maybe sprained her muscle, but really that pain in her neck followed by a focal neurologic deficit is the thing that caused the dissection. Women are for some reason more at risk for it. So what happens is the trauma causes a dissection, the dissection ruptures, and then a acute thrombus forms on top of that and embolizes elsewhere. The last one has nothing to do with ischemic stroke. It's to remind you of the words that people are going to use when they want to focus you onto a brain bleed. Especially true of subarachnoid hemorrhage, they're going to give you the thunderclap headache. Now, they will never use the word thunderclap. They'll say worst headache of their life, preceded by some sentinel event. Or it might actually be an intracerebral hemorrhage where they present with Cushing's syndrome or Cushing's reflex. That is going to be a bradycardia while there's an elevated blood pressure. And watch out, because here comes the herniation. Obtundation could also be presentation of a stroke. Let's stay focused on the ischemic strokes. When someone comes in with a focal neurologic deficit, the first thing that's going to happen is we're going to get a non-con CT, non-contrasted CT of the head. What's the deal with a non-con emphasis? It has to be done quickly. We're trying to decide, is this a stroke or not? Can we give the clot buster to save brain? What the non-contrasted CT does is essentially give you an X-ray that you can see in 3 dimensions. And most people think it's to find the stroke. Not true. The non-con CT of the head does one thing. Blood, no blood. Blood is white on a CT scan. If there were contrast, you wouldn't know if that was contrast extravasating or something else. But also, the non-con CT head is done immediately. No need to wait for the contrast to be given and 30 minutes later to take the scan. Non-con of the head means blood, no blood. You can also see midline shifts, but that's not what we're going for here. If you find that there's blood, you have diagnosed a hemorrhagic stroke. There's very little you can do for this person. If there's a hemorrhagic stroke, we're going to drop their blood pressure a lot with a drip in the unit. And then we're going to call neurosurgery and pray. Neurosurgery will decide to coil, clip, or craniotomy. As the bleeding gets worse into the skull, there's no room for the expanding hematoma. So the brain gets pushed aside, intracerebral pressure goes up, it could herniate. The only way a surgeon can prevent that from happening is by removing the skull as a release valve. Clips go on top of a blood vessel, which means they'd have to open the skull to get in there to do it, and a coil is endovascular, goes in. Endovascular coils are usually used for subarachnoid hemorrhages. It's difficult to manage most brain bleeds surgically, so that's why I say call surgery and pray. But what we can do is give fresh frozen plasma, if and only if there's an anticoagulation. That is, if the INR is elevated. It doesn't really work in the non-vitamin K oral anticoagulants. It doesn't really work in antiplatelets, but if there's any derangement in the INR, give FFP. That can turn off the bleeding, at least buy you some time. But we're going to focus our attention to the ischemic stroke, so no blood. And as soon as you know that it's a stroke, that's ischemic, without any blood, you decide, do we give TPA or not? We'll talk about that in the management section that follows. That's the ER's work. Patient stabilized, not dead. During the hospital admission, which I call the next day, it doesn't have to be literally the next day, it could be the same day or a couple days after. You will search for the etiology of that stroke. And to do that, you're going to get three main tests. The EKG, now you're probably going to have an ECG from the original TPA decision, right? But you put them on a 24-hour Holter monitor, you monitor their heart rate, checking for arrhythmias. You're going to get a 2D echocardiogram, transthoracic, and a carotid ultrasound. Every patient admitted for a stroke gets these. What you're looking for from the EKG is AFib, a flutter. If you have AFib, a flutter, and you've had a stroke, the CHADS-2 score is 2, and therefore immediately you're getting anticoagulation. Anticoagulation means either warfarin or any of the new non-vitamin K oral anticoagulants. But what you don't need is heparin. Most of the time that you start these medications, especially the warfarin, we learn that we need a bridge, 5 days, or until the INR is 2 to 3, whichever is longer. For AFib, A flutter, you do not have to bridge. The 2D echocardiogram could show vegetation. Remember, we're talking about the platelet-derived thrombotic embolic stroke. What we're looking for is a thrombus, often found in the setting of AFib, A flutter. These patients also need anticoagulation, either with warfarin or non-vitamin K oral anticoagulant. Only if you're going to do warfarin, this person will need a heparin bridge. The only thing you can be sure that does not require a heparin bridge is AFib, A flutter. And the carotid ultrasound is used to determine if there is carotid artery stenosis. And based on the size of the lesions and the symptoms, you determine what you're going to do next. If the lesion is not that bad, that it is less than 70% and no symptoms, you're simply going to treat medically. And since we're treating a stroke and the strokes are vasculopaths, we're going to cover the treatment for carotid artery stenosis. If, however, we find that there's a big lesion, either greater than 80% or greater than 70%, and symptomatic to the stroke the person just had, we're going to intervene surgically. That could be in the form of a carotid endarterectomy or a stenting. Stenting is generally reserved for patients who can't tolerate the endarterectomy, the open surgery. And there's a big switch in the way we think about things now. This is the brain. This is the area of stroke. The area around that has a penumbra. The cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. Why we do the craniotomy is because the intracerebral pressure increases and it will squish the brain through the skull. What we were worried about is that penumbra is at risk. It's tissue that could survive if we treat it right. And we thought putting someone under anesthesia for the procedure would drop the blood pressure and would end up compromising the penumbra. Fairly reasonable thing to assume. Well, it turns out we were wrong. Just in the same way that stuttering angina is unstable angina, and we cath and stent, just as we cath a STEMI during the acute event, we've now learned that if we're going to surgically intervene, it should be within 2 weeks that we do it. And it used to be wait 2 weeks to do it. And if you have recurring TIAs or a stroke in evolution, you can actually intervene on the lesion during the stroke. Big change, but something you should look for. And of course, once they have these procedures, they're still going to need to treat them medically. Pathogenesis, patient presentation, diagnostic workup. How do you treat? We're going to divide this into the acute phase of treatment, that is the very first few hours in the ER, and then the chronic phase. What do we need to do once the patient leaves the hospital? We want to talk about who can we TPA, and that's the major decision point, TPA or not, because it changes everything else that follows. And then I want to talk about, do we do heparin? Do we do anticoagulation? Antiplatelets? And then other risk factor modification like statins, diabetes control, and blood pressure control. First, TPA. TPA is a clot buster. It's going to dissolve the clot and reperfuse the brain. That's good. The bad side to this is that it breaks up all clots everywhere. It can cause the ischemic stroke to turn hemorrhagic, or it can cause you to bleed anywhere else. And if you bleed on TPA, you die because there's no way to turn it off because we just undid every clot there was. So in order to use it, the stroke has to be new. And traditionally it has been less than 3 hours is the limit. Recent literature has pushed it to be less than 4.5 hours for non-diabetics. On the test, the good news is they're not going to give you something in between. They can't. It's either going to be the person who is having a stroke and 30 minutes ago it started, the person who was walking down the street doing fine, having a conversation, oh yeah, I'm having a stroke. That acute change, got it. The timing also begins from the last time they were seen normal, which means if they were normal last night and they went to sleep, you start the clock times 0 when they went to sleep, which is why a lot of people don't get this. If you decide that they are within the window, then you also have to determine that you can get their blood pressure down on a drip in the ICU to 180/105. What you'll see actually happen is the providers will decide how bad is this stroke versus what's the risk of hemorrhagic conversion, what's the risk of bleeding. To illustrate the point, if I lost my right pinky and I was at hour 5, probably not worth any risk. If I lost the entire left side of my body and I was going to be bedbound for the rest of my life and I'm begging for TPA and it's hour 3.5 but I got diabetes, maybe you'd give it anyway. So you'll see providers, neurologists, choosing to do TPA on somebody that you think, this doesn't meet the parameters, or not doing TPA for another reason, like they're improving or it looks like a TIA or there's no evidence of the stroke. They don't want to risk it. So the decision to TPA or not is actually much harder than what we're describing. But what I want you to see, obvious stroke, no bleed, less than 3 hours, give it. Or it's going to be the person was last seen normal 2 days ago, too late, no need to worry about it now. Within the window, get the blood pressure controlled and have no contraindications. And the complete absolute contraindications are going to be a previous intracerebral hemorrhage anytime ever. Risk of bleeding, and the way they usually trick you with bleeding is going to be a recent GI bleed or any recent surgeries within 2 weeks. That's because we don't want the brain to bleed, the body to bleed, or the wound site to bleed. Obviously, there's no use of TPA chronically. The rest of the stuff you don't do if you TPA them, right? If you TPA them, they go to the unit, Q1 hour neurochecks, the blood pressure is monitored, and the next day you can start the chronic treatment. The other acute things you don't even have to worry about because they're going to be in the unit for at least 12 hours. Don't give heparin in the acute phase. No utility to it at all. Unless there's another reason to give it, like a completely different diagnosis, you can give it, but that's going to increase the risk of bleeding. So generally it's not considered something you do for stroke. Anticoagulation takes too long to work, no benefit in the acute phase. If they didn't get TPA, they need antiplatelets. And aspirin 325 is the right answer. There are some things out there that say we should do dual antiplatelet therapy, aspirin and clopidogrel. Not strong enough to recommend it, don't have to learn it, aspirin only. The statin doesn't do anything necessarily in the early phase, and you're not going to give it to them if they're NPO, so don't worry about the statin. But you do want to ensure that the diabetes is controlled. You don't need super tight control. Get it as good as you can, but you don't want hypoglycemia. That'll be worse than just having an elevated blood sugar. And the blood pressure is going to be given permissive hypertension for the first 24 hours. Permissive hypertension is defined by 220 over 120. Your protocol may vary in your hospital, but it's basically way out of control blood pressure that you would never tolerate in anyone else. You say, fine. Why do we do this? Back to the penumbra. Right? There's a blockage in the blood vessel. The tissue behind it is not getting the blood it needs. It thinks that the cerebral perfusion pressure is low, and it's low to them because it's not getting any blood. So the body compensates by increasing the mean arterial pressure, increasing the blood pressure to try to perfuse whatever it can through whatever hole there is in that clot to save the penumbra. The blood pressure goes up to perfuse the brain. Diabetes and oxygen go along with it. If you have too much blood sugar, it causes problems, especially long term. But if you have hypoglycemia, it's as if you're not being perfused, that's even worse. So while you might use insulins to control the diabetes, the goal is not to get rigorous control in the first 24 hours, but only to do that afterwards. Chronically, you're not going to treat anyone with heparin, but here's the gotcha. You might end up treating someone with low molecular weight heparin who has a severe debility, even a hemorrhagic stroke. After 24 hours of being stable, you want to anticoagulate them to prevent DVTs. So while you don't give therapeutic low molecular weight heparin or a bolus of unfractionated heparin to treat stroke, you might find some people on prophylactic doses in order to prevent DVTs, because these patients are the highest risk for DVTs. Anticoagulation is only done in the setting of AFib, aflutter, or a valve. That is, it's not done for the stroke, it's done for the individual disease. But to Chad's 2 score says AFib, 2 points, now gets anticoagulation. Which you pick, the NOAC or the warfarin, is up to you and your patients. Antiplatelets, the tradition has been give aspirin 81 daily. If you fail aspirin, add dipyrimidol. That's Agrinox. And now people are saying we should maybe add clopidogrel. Well, the tradition has been if aspirin fails and is not tolerated, switch to clopidogrel. There's been recent studies that have shown us that acutely for the first month maybe it's beneficial, but long-term it ends to more bleeding. We don't have sufficient evidence, and right now this is in contention between different providers. So with contention means they're not going to ask you. So as long as you know that you're supposed to give aspirin, that's probably enough. And because they're vasculopaths, we're going to try to treat them for their vascular disease. Statins, high potency statin. High potency statin are atorvastatin 40 milligrams or 80, rosuvastatin 20 milligrams or 40. You want to maximize the ability to reduce the recurrence risk of another stroke. That's really all you can do. You either TPA'd them or didn't. After that, it's just rehabilitation and prevention of the next one. Further to prevent the next one, diabetes control. You need the A1C under 8. Use whatever you can to get there. Obviously, 7% is a better goal, but 8% eliminates the risk of recurrence, and you'll get there with oral medications and insulins. And finally, blood pressure. We learned in the hypertension update that we're not really sure what the blood pressure target is anymore, but the idea is control the blood pressure using ACE inhibitors and diuretics or other medications based on comorbid conditions. It's more important that you get them to stop smoking, get them on a statin, and control their diabetes. Blood pressure should be controlled. It seems like a lot, right? 3 different types of strokes, thrombotic and embolic, which are treated as ischemic, hemorrhagic, which is different because of brain bleed, presenting as a focal neurologic deficit in these different categories, the vasculopath, AFib, or the bad valve with not taking their medications, or the dissection young lady, or the thunderclap headache, or someone who's going to herniate from a brain bleed. You do need to link up the location of the arteries to the things they feed. No, the first step is to get a non-con CT of the head to determine blood, no blood. TPA. Less than 3 hours, blood pressure controlled, no contraindications, give it. The next day, you find out the etiology. EKG, echo, carotid. That's what everyone has to get. You notice I left out the MRI. You can get an MRI, but the MRI is only useful when you don't know if there's a stroke or not. While you could get an MRA during the MRI and to do the carotid ultrasound instead, and while you could use a CT angiogram if you don't have the ability to get an MRI, MRI metal, CTA contrast, you don't need these things. If you have a clinical diagnosis of stroke and everything matches, you don't have to get the MRI, MRA, or CTA. They have their utilities, but if you think it's simply a thrombotic stroke, no need to do those. It's an extra wasted test. ECG, echo, carotid has to be done on everybody to rule out AFib flutter, thrombus, and carotid artery stenosis. New update, carotid artery stenosis, do surgical intervention within 2 weeks if you find it. Don't wait. And then decide between TPA or aspirin. Don't forget permissive hypertension. And then make sure your patient's on the right things. And this sounds like a lot, but if I just summarize it, a person who comes into the hospital has the same orders over and over. Imaging, EKG, echo, ultrasound. The non-cons have been already done. Medications, aspirin, statin. The special case of vitals, permissive hypertension. Risk factor assessment from labs, A1C, TSH, cholesterol panel, and the regular stuff. And because their function will be inhibited, the ancillary staff needs to be brought on board as well. That's speech therapy to get them to swallow, clear them for oral intake, occupational therapy, and physical therapy to decide what their level of function is and where they need to go afterwards. That is, do they need to go to a skilled nursing facility in order to recuperate, in which case low molecular weight heparin is going to be necessary because they're a DVT risk. That is stroke.